it's crazy, but it's
You're watching Channel Zed, the world's leading zombie apocalypse channel, broadcasting live from Studio Zed.
Makes me act the way I do.
And hello, everybody. Welcome to another episode of the Dr. Zed Show on Channel Zed, a production of Zombified Media. And as always, I am your host, Joe Alcock, MD, aka Dr. Zed. I'm an emergency physician and evolutionary medicine researcher. These days, of course, I'm interested in all things apocalyptic, including the demise of our current pandemic apocalypse. Will we vaccinate our way out of the pandemic? Where are you in line for the vaccine? Well, today we're going to explore these topics. We're going to do a deep dive into this effort and figure out what's the best way to vaccinate ourselves out of this mess that we're in. So to answer that question, we'll be joined by Esma Gel, who's an associate professor of industrial engineering at Arizona State University. Later on, we'll be joined by infectious disease expert Jessica Brinkworth, and of course, Athena Actipis, who is evolutionary psychologist at Arizona State University. There she is. She'll be part of the conversation too. So hi, Athena.
Hey, how are you doing, Dr. Zed?
Dr. Zed's doing okay. Yeah, absolutely. You know, it is spring break. Spring is in the air. There's reasons for hope, I think. I read recently that somewhere north of 4 million people were vaccinated in the United States. So yeah, I can see the post-apocalypse, I think, distantly. It's hazy. It's in the future there somewhere.
It sounds like you're cautiously optimistic.
I've been so. I'm trying to be. You know, I think there's plenty of reasons for anxiety, and believe me, we're not out of this pandemic yet. There are, as we speak, there are people in the hospital. There are people in the intensive care unit. There are people on hospice and palliative care with COVID-19. So this is still a very, very serious and difficult situation. But we're about a year into it, right? It was about a year ago that our hospital started its emergency operations center. We changed up everything that we did in the ER, and we're kind of reflecting back on that now, and you know, taking a moment to remember our losses, but also looking to the future.
Yeah, and so today for this show, we're going to talk about what's going on with the vaccine rollout and what's working, what's not, what some of the dilemmas are that kind of come up when you try to vaccinate an entire country in a few months.
Yeah, talk about a logistical challenge and also a question of justice and fairness. So we'll talk about all those fun things, and we have some real experts who are going to be on this conversation to join us, which is just fantastic. Well, maybe we should jump into it.
Yeah, let's bring on Esma Gel. Welcome.
Hi. Well, thank you.
and why don't you introduce yourself, Esma, and tell us a little bit about your modeling expertise and some of the fascinating things that you've been up to.
Well, I have been working as a modeler as part of the modeling emerging threats for Arizona team at Arizona State University. Since last March or so, we've been building models for projections in Arizona that have shown, to be pretty highly predictive of the trends and other outcomes in Arizona. The models are changing nowadays because of vaccination efforts, but we are very thankful that we finally have vaccines and kind of a light at the end of the tunnel, basically.
Yeah. So how is the vaccination process going, say, in Arizona? We'll start there.
I think things are going well. Last time I looked at the data, it looks like, the number of vaccinations per day is highly nonlinearly increasing. So that's very good. It's not exponential increase, but it is nonlinear increase. So every day it's, it's going higher and higher and higher. So I think that's very good news for Arizona. It's quickly ramped up, and they've instituted really highly effective centralized location at State Farm Stadium in Glendale in Arizona here, and it was 24/7 round the clock, and managed by experts in operations, National Guard. So I think it's gone pretty well in Arizona, thankfully.
Yeah, my folks got vaccinated, I think, by a National Guard kind of a contingent So yeah, maybe that's the best way to do it. In New Mexico, where I live, we've had a rollout, which I think is quite successful. Over a quarter of the adult population of New Mexico who are eligible for the vaccine have at least received one vaccine. And we're kind of moving those numbers up every day, of course.
So Esma,
Yes,
you mentioned this idea of sort of the operation side of things and the logistics side of things. So that's a lot of your expertise, right? Is in how do you actually set up systems for getting things to people? So what is this whole field and how is it relevant for vaccine rollout?
It is very relevant, but because of the timeline, I can't really quite say that industrial engineers were in the picture that much. But there are a lot of experts in operations. It's not just industrial engineers or operations researchers. A lot of the commercial industry actually does this on a daily basis, right? When you think of what Amazon does, UPS does, FedEx does on a daily basis, it is very high scale operations of this sort. And military operations are already very well established with good, techniques and practice. So I think that's what we are benefiting from these days, with National Guard being actually very much involved with these sites. Operations is very important for these kinds of settings, actually. And it's important to consider the various kinds of challenges that it brings.
That made me think about the movie Contagion, which actually did a pretty good job of kind of foreshadowing what this pandemic was going to be like. But of course, at the end of it, they did vaccinate their way out of that fictional pandemic. And of course, the National Guard and military were involved in that too. I'm not sure if that's the best way.
We have a question from Liz. She's asking how vaccine rollout is being prioritized in different states. So, what's different and why is it different across different states?
Because I believe early on, the federal government left it to the states and actually counties. States actually, like in Arizona, we were thinking that the counties were going to, be the governing decision maker. I think later on, a lot of things got kind of centralized within the state is my observation. We've actually when we look at the data, there's about 16 different ways that states have taken, to prioritize the vaccines. So it's a very, very diverse playing field.
So you mean 16 different sets of rules, right?
Yeah, kind of.
Age, like what your role is in society.
Yeah, age, employment, right. Based on those things, there's about 16 different ways that, states have come up with and implemented, basically. And as a result, they're, like the population segments that they vaccinate end up different, of course. They build different immunity in different segments of their populations.
That's interesting. Yeah. And I think, Esma, you had maybe mentioned something about, was it you who talked about the 1918 flu?
Maybe. Yeah, we've been interested in kind of looking at these vaccination prioritization policies and how that, kind of impacts things. And we were comparing the experience with the Spanish flu, and there are papers from Spanish flu, experience that, prioritization should be completely different. School-age children and 30 to 39 was actually the prioritization for influenza. So this has been quite a different experience in comparison to our previous epidemics,
quite different.
Or pandemics. Mm-hmm.
But still, learning from that history, I think, is so important and interesting. There was kind of a famous New York Times piece and the Daily podcast where one of the experts there was saying that this pandemic was going to follow the contours of the 1918 influenza pandemic. And by and large, I think that's actually true, both in terms of the impact it's had, the amount of mortality that we've been dealing with, the resistance in some places to public health measures, well, in a lot of places, especially Arizona, maybe. But of course, the big difference is that COVID-19 doesn't affect kids in the same way that pandemic flu did back in 1918. So thank God for that.
We have an infectious disease expert just waiting to get in here.
We do.
Let's bring Jessica Brinkworth on to join the conversation. Jessica, what do you think about, what's been going on with the vaccine rollout? Should we be doing things differently? What are your thoughts?
Are you as optimistic as we are,
No.
Jessica? No, I heard it now.
But I never am. For one, and I'm sure that you guys have heard the news that Italy is clamping down right now because the cases are climbing in Europe, and Italy is facing like similar numbers to what they were facing this time last year.
That is scary, and it's very different from what's happening here in North America.
Yeah.
So why is that?
I mean, it could. Nobody has an immediate explanation for why this is happening. You know, of course, the restrictions have been loosened over the course of the year, so that's one possibility. If you loosen restrictions around like human movement and whatnot, you are going to see cases climb. But there's also, you know, the virus has been around for a while now. We're aware that there are variants that are becoming dominant, and so that's always a possibility as well, that you just have a more competitive virus that's circulating in a particular region. So we'll find out.
That's a scary thought. And then Liz made a comment a moment ago about how comparing COVID-19 and influenza, the 1918 pandemic, would be good. And I agree. We'll do an autopsy, hopefully when this pandemic is done. And we can do a compare and contrast, which would be great.
I mean, one of the big differences that you would see right away there is that the death toll for 1918 flu was people generally between the ages of 24 and 40, right? Like that was the window of where most of the death was happening. And here we have people that are largely over 65 that are taking the hit, right?
Right.
But we're discovering new things too. So I had recently read a reanalysis of Coveted Toes as possibly just being chilblains. There's lots of opinions that are floating around now about some of these symptoms that we've.
Well, what are Coveted Toes?
So Coveted Toes are red, itchy toes, a kind of rash that happens at the lower extremity, and it was thought. And it may still be true that this was due to the infection, but it's possible that if somebody suffers from chilblains anyway, which you might see with something like Raynaud's syndrome, then, you know, if you're wandering around barefoot in your house in the springtime because you're isolating at home, you might be getting these things anyway. So
maybe Coveted Toes is not a thing.
It's possible. I mean,
we'll save that for our future episode where we
find out, right?
We can think about what were these early predictions about what we were going to be experiencing versus what we actually experienced.
So you'd asked me about how things are going. So we've already talked a little bit about this with the approach that the federal government took before the switchover to the Biden administration, was that they were going to focus on delivering millions of vaccines literally and they thought about it this way: loading docks. We're going to bring them to the states. States will figure out what to do with them. That approach has changed. So there's a couple of reasons why rollout's happening more smoothly now than it was at the beginning. And one of them is that the federal government's more involved with funding the states to get vaccines, offloading docks to other locations. There's some supply chain issues that have been fixed as well around syringes and things like that are required. And then on top of all of that, you know, there's actually vaccine to distribute. So by the time the approval was in place for Pfizer only had 20 million doses to deliver. And if you remember, the Trump administration's goal was that by December 31st, we were going to have 100 million doses out to the public, which wasn't going to be possible given what the production was. So, so now that there's more time, there's more vaccine that's rolling around, but still fraught with problems.
Aren't we almost there with our 100 million vaccinations?
I actually don't have the total number. We are at 10% of the population. So no, we're at 10% of the population as of 3 or 4 days ago. And some states are doing differently than others. So Illinois is at 12%. You guys are obviously doing super well in New Mexico and Arizona at a quarter of the population. So,
there's some pretty big variability, isn't there? And that's the American way, right?
Yeah,
we have this state-based federal system. That goes with the territory, doesn't it?
Well, yeah, and I mean, it necessitates then that big states with lots of counties are going to have very specific problems. So California has 58 counties, and they suffered from the very beginning in terms of trying to negotiate how things would move through the state. And a lot of that is because no one knew up until even a month ago how much vaccine they were going to get any given week. So that makes prioritization and planning very difficult if you can't predict what's going to show up.
Liz
talk
has a
about
question here
fairness.
about about the accessibility in rural areas. What has that been like in terms of the distribution of vaccines?
So in California, where the original approach was we're going to set up these really big vaccination centers, it went really, really bad. Like the approach was we're going to set up, everyone will come to these really big baseball diamonds and we'll just rush people in there and it'll be fine. They've had to change that approach now because, as most of you know, that California is a massive agricultural state. They have a very large migrant population that moves from California across the rest of the country that isn't, that's very low income. A lot of those people are undocumented. They don't have a means of they're disincentivized from going to these locations, or they don't have a means of getting to those locations. So there's been more reaching into communities. And so that's helped quite a bit. But that's something to keep in mind. That there's I think that when we talk about these issues, we often think that people are living in somewhat similar circumstances to ourselves. There's hundreds of thousands of people in this country that rotate across a bunch of states just to keep ag alive, and getting to those people and helping those people is has a number of challenges associated with it that need to be dealt with.
Yeah, I think we can agree that having some outreach to particularly vulnerable populations makes a lot of sense. But Esma, what do you think? What do you think is the best way from using your modeling, mathematical, analytic side to get the vaccine to basically achieve immunity?
Well, yeah, and this ties in with Liz's question here. She's, asking if are we doing it the right way now? Are we vaccinating the right populations first? She's pointing out that her cousin jumped the line in Texas, and so she's worried about whether we're vaccinating the right people first. What do you think, Esma?
I think the right way of doing things depends on the time, and that's something that we don't really discuss too much. Right. Early on, we didn't have too many vaccines, so wasting vaccines was a bad thing. So if, Liz's cousin was there at the right time and saved the vaccine from going to waste, maybe a vaccine in an arm is better than a vaccine in the dumpster. So, it's a function of a number of things. It's a number of the logistics network, the people, the service rate that we can actually support this system with, like how fast can you how many people do you have there staffing these places? What's the vaccine supply? How are people arriving to these places? So it's a number of different factors coming together to yield us this outcome of as many people as possible being vaccinated. And ideally, you want them to go to the people who need it most. But there are a number of different reasons why people might need it most. Somebody might need it most because that person is maybe old. Or somebody might need it most because that person is interacting with a number of people on a daily basis because he's working at a grocery store. So I think some of these effects are very hard to plan and, kind of model for. But we need to build a robust, resilient supply network, and it has to stand, it has to be sustainable, and it has to actually be developed over time, because I don't think this vaccination effort is going to go away anytime soon. We are actually talking about boosters now for the variants. So we need to have a nationalized vaccination system in place to support these things. Maybe we don't have a national health service, but we have some sort of national vaccine service that's actually going to be keeping track of everybody's vaccinations, and there will be something in place where people can actually know or figure out what vaccine they need to get, when, where, so on and so forth. The centralized distribution model is now changing, and there are actually organizations that are actually looking at last mile vaccine delivery for people who live in congregate settings or people who cannot really reach these very centralized locations. By design, these centralized locations were hard to get to. I was actually vaccinated at 2 a.m., for example, in the morning because I have a car to drive there and get vaccinated. A lot of people don't have that means of transportation. So we have to think about everybody when building a vaccination line like this or a vaccination system like this.
Esma, I just want to jump back to something that you sort of alluded to earlier and connect some dots and kind of put a question to all of you, which is, if some people are transmitting the virus potentially a lot because they are, working in grocery stores or schools or other situations where they're going to have a lot of contact. Does it make sense to actually prioritize giving the vaccine to people who might themselves be less vulnerable, but be more likely to act as a transmission vector and indirectly cause more harm because of that?
I think it does. I think it does. Like at one of these state meetings, I said, like if we are worried about the restaurant sector, why don't we just prioritize the restaurant sector and just vaccinate everybody? I think it would be a big boost to that sector, that industrial sector, that commercial sector, to be able to say all of our, workers are vaccinated, come and eat, or take out food. I think, it is important to consider those kinds of transmission effects. However, having said that, the mortality rate in elderly, maybe Jessica can talk about this a little bit more, but, it's so much higher. Is it 10 times? I'm not very sure, Jessica. It's so much higher that, these studies have been actually conducted with simulations, agent-based. Of course, there are shortcomings to these simulations. Sometimes we don't reflect the impact of, increased transmissibility or transmission risk in, grocery store workers, for example. We can't always put in the right numbers as input to these simulation models. But, we did study them, and because of the increased mortality, we did still go with the age-based prioritization. But maybe Jessica can correct me if I'm wrong about that.
A number of states went with a healthcare setting, like for long-term care prioritization and prison prioritization as well, for the same reasons. If you get a bunch of people together and you cram them into one spot, if they're over, if they're older or if they're under a great deal of stress, you're going to see transmission out of that location. It's not only that, but it's just cruel to not, right? Because these become hot spots of transmission, and there are long-term effects to having this infection that go beyond dying. And I think that like setting death as a bar is actually pretty brutal. Like, there's right now in this country, there's 8,800 children that have been separated from their parents at the border, and they're being kept in facilities that are also crowded, and, and their children, they're passing this infection back and forth. And so like to suggest then that the people that work in that facility, because of course children at the moment can't get the vaccine, shouldn't be vaccinated ahead of, someone who's living at home on their own and is able to self-isolate is not necessarily fair to either the kids that are there or the people that live with the people who are working there. So I think there's a bunch of different ways of like prioritizing that makes sense around just like the basic, doing the humane thing, which would be to prevent people who are at super high risk just because of how they're living. So.
But there's probably a risk to making too many rules too, right? If we try to really strongly control the pipeline of vaccines and which arms they're going into in what order, the more stringent rules and,
Yeah, I think you want to be flexible, right? You want to be flexible, and you want to be flexible with who's offering it. So to come to like New York State for a second, Andrew Cuomo's government decided that hospitals were going to start issuing the vaccine. He made this decision in December. So the big hospital systems, the ones that were being crushed under the weight of the holiday COVID outbreaks and were short-staffed and had, not enough bed space, those systems were going to be the ones that were responsible for delivering vaccines. So if you make a decision like that, you have to be willing to then go back and say, okay, this isn't working, and be as flexible as possible. And in California, when they started to suffer and they were losing lots of vaccines because they couldn't get stuff out to people, they just said, it's going to be age-based, guys. We're just whatever gets it into arms, right? Because the goal overall is really ambitious. It's to get almost 90% of the population done by the fall. And that means that if you've got a vaccine, it's got to go into someone's arm, right? Regardless of what the rules are. And I interrupted Esma, so I apologize.
No, I was going to just agree. Exactly. We have to be flexible about this, because, it's better to get the vaccine, dose of vaccine into an arm than, waste it, especially early on because of the, storage requirements. Those are being relaxed a little bit more. It was very stringent. It was hard. Logistics was hard. So, there was a non-zero number of doses that were wasted. So somebody, there's a question about punishing people who jump the line, but maybe they should feel better about not wasting. Depends on when the jump happened.
I'm inclined to
Oh.
Oh, looks like we have a interruption with maybe the apocalypse isn't over, guys. What do you think, Jessica? Should we be punishing people who jump the line?
No, I think that actually the better way to approach, first off, we have a big problem with anti-vaxxing in the country anyway. And then on
Right.
top of that, we have populations that have every reason to worry about contact with a largely white medical establishment. And so I would instead say that like it would be better to invest more energy in a carrot, right? In trying to make people be cooperative and care about, the community that they're in and what they can do to somebody else unintentionally. And I made this point to someone recently. If you took someone who was an anti-masker and you said, okay, well, here are the number of people that you made sick and here are the number of people that died because of COVID that you transmitted to them, say, and you asked them to shoot those people, they wouldn't do it. Right? Because it's horrifying. Yeah. They want to be cooperative. They want to do the right thing, right? And so what I'm saying is that like it would be better to not, don't punish them, but instead try to like push forward an idea of like, let's be cooperative. The people at risk are these people. Please wait your turn. Like that's a better way to do it.
Should we pay people then to get vaccinated? Because we will at some point have more vaccine than there are people who are able to get them.
We're willing to.
Has that ever been done before? I don't know if that's ever been done before. Does anybody know?
It's been studied in a few other contexts. Esma, we had talked about this earlier.
Yes.
About maybe even studying whether this is an effective way to get to increase vaccination uptake.
Well, that depends on like, again, time, like what timing are we, if it's a period where we have more supply, when supply is limited, you would never pay anyone, right? As the supply increases and you're trying to push on that herd immunity, trying to get to that point, we may need to, do things to incentivize people to get vaccinated, definitely, certainly. But
you certainly don't want to coerce them though, right? Like you have to, it's a delicate line between coercion because somebody needs the money and incentivizing because why not? And I'm sorry, Esma, I really did interrupt you that time.
No problem at all. I've been thinking about this. It's kind of an ethical issue, so it's best left to maybe, not engineers. But I'm thinking we're doing a lot of things for the society. Like we pay taxes, but we don't want to. I mean, we do a lot of things for the, betterment of society and others. So, I mean, this is sort of like that. As long as it's not going to harm that individual, I think I don't understand why we cannot expect to do their part.
So
we do expect that.
We're coming to the last few minutes, but I did want to put up this question from KS. KS is asking when we can expect children to get vaccinated. When will children come up in the line for vaccination?
So both Pfizer and Moderna are running trials right now, and the bar is lower for that approval. That fewer number of people are required. They just have to follow them for a certain amount of time, figure out what dose is effective and safe. But the quality for the product has already been established. They already have approvals for where it's being manufactured, so it shouldn't take very long. I've heard rumors that we'll have some kind of an emergency use authorization in June or so, but we just have to see how it works out. It's all about dose at this point and age. So yeah,
because we do expect that the vaccines are probably safe in kids. They just have to prove it.
Yeah. And it also just, and it's an issue also that you don't want to load a kid down so that they have a massive response and lots of side effects. You want to be able to find that sweet spot, right? Where you get enough to spark the response, but not enough to make a kid feel terrible for weeks on end or, days on end.
That was fascinating. I hadn't thought about that, but of course that would make a lot of sense.
Therapeutic Index, right? It's this is how much you need to be effective, and this is how much will do harm. So you want to find that sweet spot in the middle. So yeah.
Well, thank you, Jessica. And Esma, it was amazing having you on the show. I'm going to put you guys backstage. Thank you. And Joe, do you have any last thoughts as Dr. Zed, as we're moving forward with this sort of new phase of our pandemic apocalypse?
Yeah, well, we talked about the variants and the possibility, actually the inevitability, that SARS-CoV-2 will continue to evolve, even in face of some of these vaccines that we've developed with great success, I might add. And again, I think that I can't say enough about how amazing it is that we have now a variety of vaccines in our toolkit. But yeah, the virus is not going to sit still, so we have that to look forward to. I do think that with the tools of science, we will stay ahead of this game.
Great.
Yeah. So I think this wraps it up. This wraps up this episode of the Dr. Zed Show on vaccines and COVID-19. So thanks again to our terrific guests. Really enjoyed having Jessica Brinkman and Esma Gel joining us on this show. Please do join us for our very next episode. It's going to be on infectious cancer later this month, March 22nd, with Michael Metzger. So that's something to look forward to. And until then, stay safe, everybody.
It's crazy, but it seems so logical. I can't deny that there is something supernatural with you.